In this video, we'll go through a structured approach to assessing a patient with PR bleeding, covering initial assessment, key history points, physical examination, differential diagnosis, investigations, and management. Our first priority when assessing PR bleeding is to determine if the patient is hemodynamically stable. Start by assessing vital signs. Check for signs of shock like hypotension or tachycardia. Also, observe for pallor, dizziness, or syncope, which may indicate significant blood loss. Next, a detailed history can help identify the cause of bleeding. Focus on these key areas. Character of bleeding. Is it bright red blood, dark blood, or mixed with stool? Timing. When does the bleeding occur and is it related to bowel movements? Associated symptoms. Ask about abdominal pain, recent weight loss, or changes in bowel habits. Medication history. NSAIDs or anticoagulants can increase bleeding risks. Family history. Inquire about any family history of colorectal cancer or inflammatory bowel disease. On physical exam, start with general signs like pallor and abdominal tenderness. Conduct a focused abdominal exam, checking for any masses or tenderness. A digital rectal exam, or DRE, is essential. It can help detect hemorrhoids, masses, or melena, which could suggest an upper GI source. With the information from your history and exam, you can build a differential diagnosis. Common causes of PR bleeding include benign causes like hemorrhoids or anal fissures, which typically cause painless bleeding. Serious causes like colorectal cancer or diverticulosis, which may present with painless bleeding in older adults. Inflammatory conditions like ulcerative colitis, often associated with pain, diarrhea, and systemic symptoms. Keep in mind that ischemic colitis can cause PR bleeding, especially in patients with cardiovascular risk factors. For investigations, begin with basic tests. Complete blood count to evaluate anemia. Coagulation profile if the patient is on anticoagulants. Stool tests if infection is suspected. For direct visualization, colonoscopy is typically the investigation of choice, especially if you suspect a lower GI cause. In unstable patients, flexible sigmoidoscopy or angiography may be necessary to quickly identify and treat the source. Management depends on the patient's stability and the underlying cause of bleeding. In stable patients, conservative management and outpatient follow-up may be appropriate, especially if the cause is benign. However, in unstable patients with significant blood loss, initiate IV fluids, consider blood transfusion if indicated, and prepare for urgent colonoscopy or interventional radiology. Don't forget to consult specialists as needed, especially if you suspect malignancy or serious pathology. In summary, approaching PR bleeding requires a systematic assessment. Start by evaluating hemodynamic stability, gather a thorough history, perform a focused examination, develop a differential diagnosis, choose appropriate investigations, and plan initial management based on patient stability and likely cause. With these steps, you'll be able to assess PR bleeding confidently and refer appropriately. Thank you for watching. Practice this approach to build confidence in managing PR bleeding cases.